Okay, so we are now going to talk about some specific bacteria. We're going to start by talking about Staphylococcus. Staphylococcus is a gram-positive bacterium, and Staphylococcus causes a lot of different diseases in humans, and so it's a very important bacterium. Now, Staph is going to be a gram-positive cocci. And it typically will form grape clusters in culture when you do a gram stain. Now, in a person, bacteria don't always look how they look in a lab. So, in a patient sample like the one you see here, you can see some singles, some doubles, some clusters. So, it doesn't always have to follow the pattern that you see in the lab. But having the clusters in a gram stain in the lab is a sign that it could be staph. Now, staph has a polysaccharide capsule, and capsule number 5 and 8 are associated with most of the human diseases. And staph is also going to have adhesion proteins that are going to allow it to bind to our extracellular matrix. And extracellular matrix are going to be things like collagen, elastin, fibronectin. It's going to have a protein A that helps it with osmolality. It has fibronectin binding proteins A and B. And it has coagulase. And this is for Staph aureus, of course. And so these are all going to be proteins that are going to be diagnostic for the testing of Staph aureus. Now, Staph aureus does have virulence factors, and so its virulence factors are going to be its capsule. It also is going to form what is called a slime layer. And a slime layer is basically loosely bound water-soluble film. And this is, of course, going to be a biofilm. And that's going to be very protective against antibiotics because the bacteria at the edges of the biofilm will be susceptible to antibiotics, but those in the center of the biofilm will be protected. It also has a peptidoglycan, which is going to help with osmotic stability. It is a pyrogen. Of course, we know it does bind to toll-like receptor 2, and so it can cause acute phase response. It's going to, of course, have teichoic acid, which helps by binding to fibronectin, and it has protein A. Protein A is going to be responsible for cellular osmolarity, but also is going to inhibit antibody-mediated clearance because it can bind to our immunoglobulins. And then Staph aureus has a series of toxins. So it has cytotoxins, which are going to be toxic to many cells and cause hemolysis. And of course, bacteria like to cause hemolysis because then that releases a lot of nutrients that they can use. It also has something called an exfoliative toxin, and it has two of those, ETA and ETB. These are serine proteases, means it has a serine in its active site, and they're going to split intracellular bridges in your epidermis. And this is going to be an important mechanism for a disease called the scalded skin syndrome. It has enterotoxins. These are going to be superantigens that are going to cause potential shock. And so these are the ones that are going to stimulate T cell massive proliferation. They trick the T cells to think that they're getting activated. And you have toxic shock syndrome 1, which is a superantigen. And this is also going to stimulate T cell proliferation, release of cytokines, etc. Now, some virulence factors for staph are going to be enzymes. We have coagulase, and coagulase is going to be important by converting fibronectin to fibrin, and that's going to be one of the strategies that Staph aureus uses to wall itself off so that it can grow uninhibited. It has hyaluronidase, which is going to hydrolyze hyaluronic acid, and this is going to allow the bacteria to spread much more easily through the connective tissue. Fibrinolysin is going to dissolve fibrin clots. Again, it's going to be very important for it to disseminate. And the fibrinolysin is also called staphlococcus. Lipases are going to hydrolyze lipids. This is going to be important for areas of the skin, sebaceous areas. And so this is found everywhere except for the palms of the hands and the soles of the feet. And then, of course, they have nucleases, and this is important because it can dissolve those DNA nets that your neutrophils release. And so it allows them, again, to evade getting killed and also helps them to disseminate. So some of the diseases for Staph aureus are going to be our scalded skin syndrome. This is also known as Ritter's disease by the person who identified it. And so it's going to start with an abrupt onset of perioral erythema, so that's redness around the mouth. And then after that, you're going to have this redness spread to the entire body. So within 2 days, it spreads. And then this is going to have a Noelsky sign, which means slight pressure to the skin will displace the skin. And basically the upper layer of the skin is sort of shedding. Think of it kind of like a snake, and it's going to just kind of peel back. This is going to be followed by blisters, desquamation of the epithelium. And the blisters, what's interesting, it has no organisms, because this is a toxin disease. So here we're looking at toxin diseases. And so again, the organism is not found in the blisters, and then within 7 to 10 days you get antitoxin antibodies, and then it'll start to clear the toxin. And so in this case, your epithelial layer is going to sort of shed, and your epithelium then becomes intact, and you don't have any scarring because it's just the very top layer that gets damaged. This is typically a disease of children and neonates. Death is going to be about 5%, but it's going to be due to a secondary bacteria infection. However, in immune-compromised individuals, regardless if you're an adult or child, death can be as high as 60%. Now, food poisoning by Staph aureus, again, is an intoxication. And this is going to be due to contamination of food by human carriers. And this is unique because a lot of food poisoning is caused by animals. But this is the case, it's by human carriers, and most commonly with a carrier who has colonization in the nasopharyngeal area. Now, this is going to be most common in processed meats. Ham, salted pork, remember, Staph likes salt. And then custard-filled pastries are another common. Potato salad and ice cream. Now the bacterium gets in there, makes the toxin, and even if you heat the food, it will kill the bacteria without the toxin. Toxin is heat stable. Now, this is going to have an abrupt onset. About 4 hours. And this is because the toxin's already made. And it's going to have a rapid course. Approximately 24 hours, it'll be over. And that's again because the toxin is made, there's no bacteria there, so it can't keep making toxin. So once your body eliminates the toxin, you just go back to normal. This is only going to be supportive care. So replace fluids, try to help with abdominal cramping, things like that. The other ones caused by toxic shock syndrome is the toxic shock syndrome toxin 1 of Staph aureus is going to cause this, and that this is going to cause overactivation of CD4 cells, cytokine storm, and organ failure, etc. Now, Staph aureus doesn't only have toxins that are causing disease, they also have suppurative diseases. And so it can cause impetigo, which is going to affect young children. And impetigo is shown here. Oops. And it's going to start with a flat red spot, a small macule. Which is a flattened red spot. And then pus is going to fill a vesicle. And this equals a pustule. And this impetigo can be caused by staph or staph and strep combo. So I'll say with or without strep. So strep can be part of it, but staph will be part of it. Folliculitis is going to be a pyrogenic infection of hair follicles. And the base of the follicle gets red and raised, and there's actually pus just beneath the epidermal layer. And then if this is going to happen at the base of the eyelid, it's called a stye. Now, a furuncle or a boil is an extension of folliculitis, and this extension gets into long, painful nodules. Large, painful nodules, not long. So it's like the next stage. And this is the furuncles are going to be a fancy term for boils. And this also is going to contain dead cells and necrotic tissue. And then carbuncles are going to occur when the furuncles coalesce and get into deeper subcutaneous tissue. So sub-Q or subcutaneous tissues. And here, because you're getting more deeper into tissues, you get spread of the bacteria systemically and you start to get fevers and chills. Now, Staph aureus is also going to sometimes be found in the blood, so it's going to cause bacteremia. And unlike other bacteria where you know how the bacteria or the person got exposed to the bacteria, such as through the respiratory tract, GI tract, urinary tract, with the case of Staph aureus, sometimes it's not as obvious where the bacteria actually came from. Was it a small cut on the foot, on the hand, or was it invasion through the lungs? Things like that. But Staph aureus can definitely disseminate. And when it does gain entrance into the body, it can cause acute endocarditis. And this is a very serious disease with a mortality rate of about 50%. You're going to have nonspecific flu symptoms. And then this is going to deteriorate really rapidly into a disruptive cardiac output. And you get a peripheral septic embolism. Now, of course, Staph aureus can also cause pneumonia, and this is referred to as typical pneumonia. And so you're going to get patchy infiltrates. Remember, staph has a lot of toxins, so these toxins are going to allow it to form abscesses. And then you're going to get hematogenous pneumonia, which is common for patients who also have bacteremia or an endocarditis. So basically, both bacteremia and endocarditis means that the bacteria is spreading. And so if you also have a lung infection, this is typically going to be a hematogenous pneumonia. Now, community-acquired MRSA is going to be responsible for severe necrotizing pneumonia. And this is going to potentially to septic shock and high mortality rates. Empyema is going to be in about 10% of the patients with pneumonia. And basically, this is simply just pus that's building up between the cavity of the lung and the membrane that surrounds the lung. Okay, so osteomyelitis is going to be when you have dissemination to the bone. And this also could be caused by some sort of trauma. Now in children, staph is going to infect the long bone. And it's going to lead to sharp pain, intense pain in the bone that's infected. In adults, it's not going to affect the long bone, of course, it's going to affect mostly the vertebrae. And so this, you're going to get intense back pain and fever. And then septic arthritis is going to be found in children and adults that receive intra-articular injections. And this is usually in the larger joints. So your shoulders, knees, hips, those kind of things. Now, for diagnosis, basically you're looking for a clinical presentation, as well as can you isolate Staph aureus in the cell culture. So there's many different augurs that can do this. There's a chromogenic augur, and this makes it so that the media will change different colors depending on what staph is present. Staph aureus could be purple, Staph epidermidis might be green, and different staphs will have different colors. So it's a really quick way to see if you do have Staph aureus. Mannitol salt is, again, going to be selective for staph because they like salt. And so here's a mannitol salt, and you can see this yellow area, and that is going to be a mannitol fermenter. So Staph aureus is a mannitol fermenter. Other staph species can grow on this salt auger, but they cannot ferment mannitol. So these are just some ways to look at staph. You also have, if you have a patient experiencing food poisoning, this is going to be based on history and clinical presentation. If they just ate and within 2 hours they're in the emergency room, it's an intoxication. There's no way a bacteria can grow that quickly in the gut and produce toxins to cause food poisoning in that short period of time. There are also commercial nucleic acid tests which can ID different strains, especially for resistance like MRSA. Biochemical test, again, coagulase is very important for Staph aureus, and it'll differentiate Staph aureus from non-coagulase positive staphs. And you also have heat-stable nucleases and protein A. So treatment for Staph aureus is going to be antibiotics. So again, they're highly resistant to penicillin. Right now, about less than 10% of the Staph aureus out there are going to be susceptible to penicillin because they have a penicillinase, which is a beta-lactamase that will break up penicillin. They're also resistant to the semi-synthetic penicillin derivatives, methicillin, nafcillin, etc. MRSA is going to be resistant to all the beta-lactams, penicillin, cephalosporins, etc. And it has different genes that confer resistance. So for Staph aureus, especially if it's an antibiotic resistance, you can get oral therapy, doxycycline, for example, clindamycin, and IV therapy is going to be by vancomycin. Now just a little bit about the other staphs. So Staph epidermidis is a catalase positive, coagulase negative. So a way to tell the difference between staph and non-coagulase staphs. So typically when you talk about a staph infection, it's either Staph aureus or it's a non-coagulase staph. So Staph epidermidis is going to be a major cause of endocarditis. And it's going to be able to infect artificial heart valves. And so this is typically Staph epidermidis would be introduced at the time the heart valve was placed in, and it's going to have an indolent course. So it's going to be slow. And the signs are going to take about 1 year. Again, more than 50% of all of our catheter and shunt infections are going to be a non-coagulase staph. And it makes sense because we're all colonized with staph, so the introduction of staph into patients who are getting these instruments put into them in the hospital, the likelihood of transmitting staph versus anything else is pretty high. The other thing is staph can produce a polysaccharide slime. We talked about that slime. It forms that biofilm. And this allows it to adhere to the catheter. Or the shunt. And it also protects them from antibiotics and the immune response. Now, there's the staph epidermidis, or the non-coagulase staph, also can cause prosthetic joint infections. And this is typically going to be important for hips. And so you're going to produce localized pain and mechanical failure of the joint. Fever is often not going to be present, and the treatment is to replace the joint and to add antibiotics. And then there's a few staphs that we have a few things just to mention. So non-coagulase positive staphs can infect heart valves, transplanted heart valves. But native heart valves, if they are weakened somehow or damaged, such as through rheumatic fever, you can have an infection with a Staphlococcus aeruginosus species. However, strep is always going to be the more common cause of a native heart valve infection. So this is a note. So how to tell the difference between staph and strep? Well, we have strep, and we have staph, and we have a gram stain, and they're both positive, and we have a shape, and they're both cocci. This one tends to be in diplo or chains. This one tends to cluster or single. And then you have catalase. Strep is negative, staph is positive. And then coagulase. Strep is negative, staph is negative. And then if it was a Staph aureus, of course, that would be positive. And then finally, Staphlococcus is going to cause infections in UTI infections in young sexually active women. And really no other age group. And so these women are going to get dysuria, painful urination. They're going to get pyuria. Which is pus in the urine. And then they are going to respond to antibiotics. Because this is not caused by our Staph aureus. Okay.